So I wanted to jump in a little bit just to keep the momentum going on cervical deformity. And really, the focus has to do with implications on spinal balance. As we're going through reading, you guys are looking at old lectures that have gone through the SSF, and your own learning, you're realizing that there's a whole concept of intercontinuity of the cervical spine and implications on regional alignment and balance. So one thing that I wanted to first talk about was some questions that always come up. Sort of, are there fully established cervical deformity classifications and treatment options? Are there defined indications for surgery to correct cervical malalignment? And are there set standards to address the amount of correction needed? This involves techniques that continuously change. And what is the impact of regional cervical sagittal alignment on outcomes? It's quite impressive. So I'm going to dial it back some. We always jump into the topic in question, but really the cervical spine is responsible for the head over the body, leveling your horizontal gaze, and also balances the center of mass for the cranium, right? So any changes in any of these result in cantilever adjustments in a continuously connected spine. And there's also biomechanical stability in question. So ever since the 80s, there's been enough studies and also validated studies to know that there are sort of three joints that we need to be aware of, and also three columns, right? The anterior column, the vertebral body and the disc, and the two posterior articulating facets. Now, these contribute to load sharing and distribution of balance. So if we talk about the cervical spine, you can see that 36% of the load is in the anterior column versus 64% in the posterior column. So it makes a difference what you do as compared to the thoracolumbar, where it's almost reversed. So it's very important when you're doing posterior cervical to understand where your load sharing and distribution arises, because that implication creates a lot of iatrogenic issues. So why the lordotic cervical spine? Really for compensation for thoracic kyphosis, and then thoracic kyphosis needed for lung volume expansion, and also this increase of age. So any deviation from this flexibility in lordosis to a stiff cervical kyphotic spine increases your pain. And I prefer that any measurement of lordosis be done standing. Anybody like to measure lordosis of the cervical spine on supine films, no. MRIs, CTs? So the worst thing that anybody tells me is like, we looked at a CT, the patient has a fairly kyphotic spine. And I said, well, first things first, if they can stand, it's better. Sitting next better, but certainly I would prefer standing films. And there are several ways you can measure lordosis. Cobb angle, Jackson physiological stress lines, Harrison lines, tangential lines, and degrees of accuracy. But there's always a rough measurement of C2 to C7, C7 T1 disc space for measuring of cervical angles. And you can see that it's not equally distributed in terms of the angulation in the cervical spine. So segmental changes have different and also morbid complications. So anytime I'm doing a C1-2 fusion, I understand that I am literally going to cause more problems if things are not taken into consideration due to the burden of the lordosis at that level. And you can see that things change as we go to the subaxial spine. So the cervical spine has a region of interest, right? So it's used to be poorly studied. In the last decade, it's gotten a lot better, almost matching thoracolumbar. And we do know that with good normative data from large studies and also registries, we can appreciate the radiographic, the health-related quality of life measurements, and also the overall global effect. And to know that pathologies that affect alignment lead to disability. There's no question about that now. And this disability could affect breathing, swallowing, including myelopathy, radiculopathy that we traditionally know about. And there are also other regional effects, including global spinal alignment and the compensatory pelvic tilt, etc., that leads to or begets more deformity. And also there's also the repercussions associated with anything that we do in the upper cervical spine, leading to the subaxial spine undergoing excessive hyperlordosis, added degeneration, and a poor chain reaction downstream. You can look at this cartoon drawing that says, column A, normal cervical spine, well aligned. In a hyperkyphotic cervical spine, you can see how the patient is, or should I say, the figure is showing how there's compensatory tilt mechanisms down the spine. So long fusions begets issues if you don't do it properly the first time. In a hyperlordotic spine, compensatory kyphotic and also rotational tilt, right? So this is how the neck affects, the lower back. Consequently, down this lecture, I'm going to show you issue and also make the case of how the back affects the neck. And there are papers with actual patient data to demonstrate that. One of the things that is not very clear, it has to do with how there's an increase in posterior cervical fusions for deformity correction, and understanding of the implications. There's also wide studies about the disability index of cervical deformity. This doesn't show as well as, but if you look at somebody undergoing significant cervical kyphotic malalignment or cervical deformity, cervical thoracic deformity, it's as if you looked at their disability and health-related issues on a daily basis, it's as if they live right in between somebody who's dealing with chronic emphysema and significant blindness. That's how it impacts their daily life. And if we wanted to put it in a measure of percentile as to how they function daily. So this really impacts people's function. So I'm going to talk about just 3 measurements that I find really useful. Dr. Chapman mentioned one of them, which I'll also harp on, but translation. So in Pittsburgh, I call something called the Cobra neck, which is you get somebody coming to your clinic, he's got a long fusion from C2 to T1, and you look at his cervical thoracic junction, it's under a lot of strain. And that's because they decided to make sure that we want to have an easier time putting in the rod. We just put in a flat, long rod. There was no bend to it. And positioning, as Dr. Chapman mentioned, they positioned the patient in a flex position, did not do any post instrumentation realignment. So you can see that there's a tight standard deviation where people's translation from their cervical SVA exists. And the worse or the increase in their SVA leads to more deformity. And it's really tight. It lives in it's a mean of about 15 millimeters. So anytime this increases up to about 40, beyond 40, there's a lack of compensation. Now, if somebody has a thoracolumbar fusion, it's harder for them to adjust to that. So in a person who has not had a fusion before, compensating, doesn't have autofusion elsewhere, it's easy for them to compensate. But anytime you're going beyond 4 in translation, it's harder. So I always say positioning, the easiest cheat way to do it, if you don't have x-rays to look and you're positioning long cassette x-rays supine, is to always have this attentiveness to say the occiput should, the back of the head should line up or just be slightly higher than the thoracic hump. And that's if you haven't artificially ruined your thoracic hump with your chest rolls, etc. So that gives you a perfect window of how they can compensate. Now, why does this matter? And you saw this figure by Dr. Chapman. It's saying it's as if in the normal alignment, it's as if you're carrying a 12-pound load versus 42 pounds as your SVA translate. Things get worse. There's a third, there's a second thing that I want to mention, which is the chin-brow vertical angle. And that literally gets to the point where they are using all methods of compensatory in all limbs. So you have somebody who can barely look up. They have to maintain their horizontal gaze. They now have hip extension versus knee flexion just to balance and look forward. And you've seen them all. You've seen them in our deformity clinic. You've seen them post-operatively come in. This person right down to the right now has not just a cobra neck from a long rod in their back of the neck, but they also have an exaggerated thoracic hump and their knees. So imagine if they come and then they'll say, oh, I just saw a rheumatologist. I am on multiple disease-modifying agents because they said I have flagrant rheumatologic disease, even though my markers are not exactly where they should be. So all of these things matter. Some of these show up with musculoskeletal issues, but I always worry about our iatrogenic effect, our poor planning, poor understanding of the whole global alignment with regards to cervical deformity, and also a lack of understanding of saying, you just don't show up and say, yep, it's myelopathic, I am going to do my laminectomies, drop the rods, and go home. It doesn't work that way. How many people expect everybody who's going to be having a long posterior construct, I'm talking more than 4 levels in the cervical spine, either anterior or posterior, do get scoliosis standing films in your institution? Can you show by hand? I can see this. So less than 25%. So you see where I'm going at right now. So it's like, okay, I saw Mrs. Jones. We're going to do 3-level anterior cervical surgery, but I have no idea how her cervical thoracic junction matters. I have no idea how, when I look at her, what's going to matter. All I'm thinking about is 3 herniated disc. We're going to put a plate on. I have no idea how to contour this plate. I have no idea how to. So you can see we're practicing in a vacuum, and we're begetting more deformity. And I'm saying that these days, the work that I do is getting more on the patients because we have technology to put in more screws, more longer construct, and the deformity is getting harder and harder to correct for the patient. Okay, that means we're doing longer constructs to offset our ability to create bigger problems. So we've talked about the translation SVA. I also want to mention quickly, we've talked about the chin, what we call chin on chest, as the chin-brow vertical angle. And now, a lot of things that I want people to, if you did long cassette x-rays, right, we'll be able to talk about things that affect the cervical thoracic junction. That has a regional effect on the cervical spine as well as a downstream effect, which is the T1 slope, T1 inclination, which determines the amount of cervical lordosis. So let's go beyond not getting long cassette x-rays, looking at how people stand, their whole global balance, right? And the understanding is that a small T1 angle, you need a smaller cervical lordosis to maintain physiologic neck tilting. We've talked about how this creates disability, how this impacts your quality of life. So what are some of the drivers that we need to be aware of, right? And paper after paper over the last decade is showing how much cervical lordosis do you need based on your T1 slope, sagittal alignment. And you could see that these 3 different patients created iatrogenically, some physiologically, some by trauma, right? So first patient on the left, they have a T1 slope of 79 degrees. They need a huge cervical lordosis to maintain horizontal gaze, to be physiologically aligned. There's some iatrogenic issues there, but the data and measurements correlate with that. And then you look at the middle person, sort of I'll call them moderate, right? They do have some issues with excessive kyphosis, causing some lordosis, but because they have a sort of just outside the range of T1 slope, they don't need as much lordosis versus somebody with a very little, very little T1 slope angle. They can even live with kyphosis. And if you ask yourself which one of these are having issues, you would think, oh, it's going to be the number 3 or to the right because they have obviously cervical kyphosis. But they actually are better off and they feel better if you ask them on HRQL with regards to the one on the further on the left. So it does matter, and that's one of those things that now papers are coming out to say, wow, we're not just looking at the stenosis, we're not looking at cord compression, cord stretch, we're also looking at how their global alignment looks like. So you can't take these regional changes in vacuum. You have to consider global alignment that affects typically the regional alignment as well. So we know that this lives, like the T1 angle slope lives in a very tight range of about 17 degrees. Anything bigger than that, you have to plan for a difference in your cervical lordosis to maintain physiological alignment. And it's more and more, we have more in our armamentarium in terms of what we do, ventral approach versus dorsal versus combined. And the outcomes of surgery matter in terms of how powerful you want to realign these patients. And you can also recognize that, as Dr. Chapman mentioned, that you can get a certain degree of correction ventrally versus dorsally versus a combined approach. Now, all of these standardized, if you look at it with cervical deformity versus, anterior versus posterior or combined, they show significant improvement in your neck disability index, EQ5D, and other pain drivers in health-related quality of life if your alignment is within a tight range, which we call close to normative, age matched, etc. But it doesn't come cheaply, right? So the longer, bigger deformity procedures we have to do, we have to talk about complications, right? Dysphagia, early complications versus late. Infection, of course, the wound dehiscence, as we mentioned, and also nerve palsies, right? So, and you also worry when you realign people about how they inhale, respiratory depression, and of course, mortality. So if you look at this all in continuum, it's very obvious. Anterior has less versus posterior versus a combined approach. But you move towards a combined approach, you're looking at more and more extensive surgery to correct bigger deformities. So the bigger deformities we're creating equals bigger surgeries. And I'm always leery of creating bigger iatrogenic deformity because, it's not going to be us that regulates ourselves if we're willy-nilly doing this without a plan. Translation, cervical SVA. Are you looking at your T1 angle? How many cervical long fusions are you doing where you don't even know how the patient, when they stand, how they look like? And you realize that sooner or later, once you become the custodian of doing these deformities, your partners are referring to you because they do quote unquote degen. You come to realize that no, it's not just degen, it's spinal surgery. I need to consider every angle, every regional alignment to do it right. And once you start this course, you'll be able to correct things that they didn't know, things that they didn't train, and it becomes very normative for us to consider alignment, which is a marker of disability and also a driver of pain. So if somebody has a moderate mid-cervical apex disease, it's kind of split now, and it's always evolving. The techniques, as I mentioned when I asked those first questions, is always evolving. anterior versus posterior versus combined, but then as you move up into bigger deformity, you're looking at cervical kyphosis with the apex at a CT junction, mostly posterior, as Dr. Chapman mentioned, anterior posterior 14 out of the 14% out of the cases that they did, versus people with chin on chest, where it's a really powerful, as to even 3% of them going as far as going into a 540 scenario, versus those who have mild cervical kyphosis, where it could be mixed. So the techniques are evolving. We are very aware of how the neck affects the back. Changes in cervical alignment correlate to HRQOL improvement in the adult thoracolumbar deformity patients. And this matters into their health status and disability. So there is also a prevalence of cervical deformity amongst patients with thoracolumbar deformity. So sometimes when I examine a patient, maybe some myelopathy, but I always want to do cervical, examine the cervical alignment in relation to thoracolumbar deformity. The shock and horror was seeing places where they do quote-unquote scoliosis codes. They put a lot of scoliosis codes. They do a lot of thoracolumbar deformity, but they still don't get long cassette. They still don't consider that into their planning. And the back also affects the neck, and it's a big deal. And obviously, how does this affect cervical deformity? Decrease in HRQOLs if you follow them long enough. So some of the pitfalls, and I know we're running out of time, so I just cut short this lecture. How do we avoid some of these cervical malalignment issues? And it's really avoiding our old techniques, right? So wiring, nobody does that anymore. So that is a big issue in terms of adult deformity. But I see this a lot, right? So I see piecemeal construct, lack of, this is the x-rays that the patient brought, and I went back and looked. There's whiteout of the cervical thoracic junction. There's no long cassette. But look at those leads. For those of you who don't know, those leads are not bone growth stimulators. They're called occipital nerve occipital nerve stimulators. And that's sort of, this patient is trying as hard as possible to compensate. And they've done this sort of bridge over the back, over the front, and you could just see that this was an opportunity for maximizing the patient's misery. I know Dr. Chapman wants to talk.
Look at Bazem's sign on the left image, right there. See that impingement of the C1 to C2?
Correct.
This is Baz's sign. This is a patient who's desperately compensating.
Yes. So, and it's very important. How do we avoid this? How do we go back and say, you need to do this alignment? They needed a bigger surgery, right? They didn't need to have this piecemeal, and then we're going to do occipital neuralgia because you're literally scrunching everything that they can. They cannot hold their neck. They have big surgery. But, it's never always about degenerative. Sometimes some culprits for iatrogenic failures are metastatic disease, infection, trauma. So this is a nice gentleman, came to me in my early practice, and he had obviously a spinal metastatic disease, vector of compression, more anterior than posterior, and we decided we're going to corpectomy. So I booked this case. I talked to my senior neurosurgeon in the practice, and the plan was, let's do a corpectomy, single level corpectomy, and let's put a cage and 2 screws above, 2 screws below. That's not going to work. Dr. Chapman showed you a lot of failures with poor anchoring, right? So these 2 puny screws were going to anchor the lollipop on the stick above cervical cranial and the bottom in somebody who was known to have metastatic spread. So you want to do something bigger. You want to anchor and you do something that is potential. And it's a hard thing for neurosurgeons to accept. And it's something that I want you to think about, not just the alignment, not just the morbidity of the surgery, but also understanding this patient has terminal disease. We want to do 1 surgery to stabilize them, right? So each patient is going to be different, but this is an example of we need to get more points of fixation based on bony infiltration, based on bone quality. Bone quality assessment matters. This is a gentleman who went and who has end-stage renal disease, had radicalopathy, degenerative, went to a community hospital, surgeon looked at it, he said, my neck is falling apart. They put in these fancy new titanium cages, plate, etc. So there's a bone bone graft mismatch. This is somebody who has poor bone healing qualities, but we're going to, because this is the rep that I use, this is the company I use, we're going to use these devices. Very poor surgery done. Well, guess what? They come to me, I realign them. You can see the staples at the back of the neck because I'm showing you this for a reason. Poor bone quality. I then, lock in down. This is about a year after I finished fellowship. So everybody's high-fiving, he's happy. Guess what? He falls forward. Not enough points of fixation, not enough understanding of the forward mechanism and motion. So things that you need to know in this day and age, right? Cervical alignment, you think about cord stretch, cord compression, but the surgery is not without high risk, right? You can have neurological injury, leading to other soft tissue injury, and also failure of alignment like I have. So it's important that you get your training while you can. That's 80% of what you do. The easiest thing that we know now is to put in the hardware due to navigation and robotics. Doing the surgery, understanding why you're placing these devices matters. Understanding alignment matters. Understanding your patient selection matters, right? So frail, no decompression alone, poor bone quality in your plastic disease, we're thinking more points of fixation. We're trying to get our training while we can. Understand that there's going to be a diversity in what you're taught, and to understand that there are principles that may not extend to where you are, that you need to get into your armamentarium, right? So physiologic, we talk about bone density. Sometimes I have to do augmentation before we do surgery. It takes about a whole year if there's no significant neurological compression or symptoms before I even contemplate doing surgery. Rigid deformity, right out of fellowship, you want to do a rigid deformity, you got to have it, buddy. Okay, there's a lot of things that could go wrong with rigid deformity. Doing osteotomies, you have to have somebody across the table that is not in training, that's not your PA that was assigned to you, that used to put stimulator pumps with the old surgeon that retired, right? So preoperative assessment, nutritional status of the patient, right? Before you do all these things, wound breakdown assessment, you have to know that you've totally considered, as opposed to when you were a fellow and a resident, you looked at the images and then you let Dr. Chapman figure out these hard stuff. This is you. This is not just his clinic. This is your clinic, your preoperative assessment. You are the deformity lady of your group, and you have to prevail, right? So when I look at this, I always say, whenever I give a cervical spine talk, I look at it in a global spine picture. Thoracolumbar malalignment impacts cervical spine. Cervical malalignment impacts thoracolumbar alignment. The T1 slope is becoming more obvious as a driver of that cervical thoracic bridging point. But as I always end, it's not about your compensation, but it's about the patient's compensation, right? The cone of equilibrium that you have to maintain. And it's very important that we do right all the time. Thank you.
Let me ask the great Kojo Hamilton 2 questions. You're always a voice of reason. I appreciate that. Very nice lecture. Number 1, swallowing and kyphosis. So when and where do you get swallowing tests? At what kyphosis angle, especially in rigid kyphosis, is this essential? And when do you use a PEG tube beforehand, prior to deformity correction, to not go into that rat race of malnutrition, aspiration, SLP consults, which are non-helpful?
Right. That's a great question, actually. So anytime anybody has had more than one anterior cervical operation, no matter how small, I'm very keen on getting not just vocal cord, but swallowing evaluation pre-op. There may be some compensatory movement that they do that they're not aware as a result of their deficiency in being able to swallow normally. And so I'm going to lock them in posteriorly or go anteriorly again. So I'm always saying, if you've had more than 2 surgeries anteriorly, I want you to do it. Rigid deformities is an absolute must. Rigid deformities with a significant cervicothoracic cervical deformity, I want to do that first because they're actually compensating in a wildly unusual way. And I always say that is a must. Now, it's rare these days to end up having somebody get a preoperative peg tube. Sometimes I end up having them go with a drop-off before to say, let's do this for 2 weeks. There's great, at least in our region, the United States, there's great home health, nutritional support that can be done even without going to a place. But if there's significant mental challenges, people with cerebral palsy, et cetera, that I know that I know that they may not be able to cope, then I get our general surgeons involved. And it's always important, even if they're resistant, to have that discussion first. It won't scare anybody away. The patient that runs away because of your preoperative discussion is probably a savior for you in terms of downstream problems. Never be afraid of telling them about your complications. Remember, 100% complication rate. We want it to be, you complain about your tape blister from an IV versus something that will alter your life. And I always say, if I give you the discussion and there's a tear in somebody with severe deformity, we're going in, and there's not a tear in the room, bad idea, right? And I'm not consenting you for any major surgery when you just rolled in by yourself because everybody was too busy.
Important nugget. Yeah. A patient who does not like your pre-op discussion, you probably don't want to do their surgery.
You do not want to do the surgery.
It's a very important nugget.
Yeah.
One little pitch, by the way, one of the most mispronounced terms in the cervical spine literature is that of swallowing difficulty. It's not dysphagia. You didn't say it. It's dysphagia. Right. Yeah. Dysphagia is actually a vocal cord problem. So dysphagia is the proper pronunciation. Most underreported complication of any anterior neck surgery. 30% plus, right? Would you agree?
Correct.
And by the way, Dobhoff tubes in a geriatric population are worse. So in a geriatric odontoid fracture study, we kind of put them aggressively on feeding tubes. And the side product was they had a way higher aspiration rate when they had feeding tubes than without. So we actually found out that this is an unwanted side effect of this insight. They had a higher problem in the geriatric population because they can't control their saliva secretions around the tube. So just, again, my personal pitch is if you have a bad deformity correction, think about a peg tube, but clearly have a nice swallowing test beforehand.
Yes.
Second question. Industry loves MIS, and we think MIS is the only way we can approach the thoracolumbar spine now because, oh my God, we're hurting patients so much when we open up the midline. Where are we in the cervical and cervicothoracic junction with so-called MIS benefits?
We're not there yet.
So we still cut open the spine, and they heal?
They do heal, and
wow.
They do heal. And I have to tell you, now the MIS practitioners are saying ACDFs are considered MIS. So I think, Dr. Chapman, if you do any anterior surgery, you're doing MIS too.
Rod, I'm an MIS surgeon. I want to be invited to the next course. Yeah. I was not invited this year.
All right. Any questions at all?
Otherwise, great sequitur to...